Hi, my name is Sam Smith, Senior Vice President for Business Development for Axxess. I'd like to welcome you to the Axxess webinar on value-based purchasing. This webinar should help you understand the measures that are being introduced by CMS to introduce the value-based purchasing system. The system is a reality for 9 states, and we think it's only a matter of time before it gets introduced nationwide. We've gathered a panel of experts that have been working in home health care for years and who keep their pulse on what's happening in the industry and how we can be prepared to deal with the changes that will come with value-based purchasing. Before we get started, I'd like to introduce our panel today. Jennifer Gibson is our clinical expert and lead teacher in ICD-10 coding. She'll be talking about clinical quality standards and population health standards. Dr. Andrew Wanayi has his doctorate in nursing and has worked for years in care coordination and patient satisfaction. He leads our education and research efforts here at Axxess, and he'll be talking about the patient satisfaction and safety measures that are in the value-based purchasing scheme. And last but not least, we'll have Marvin Havellana talking about care coordination and effectiveness measures in the home health setting. Marvin is the CEO and owner of Better Care Home Health in Illinois, and his creative solutions to the management of populations has become pretty well known around the post-acute world, at least in the Chicago area. Everything we'll talk about today will ultimately feed into the triple aim to improve healthcare. The 3 aims you might be familiar with: population health, the experience of patient care, and the reduction of cost across the entire care continuum. And not only that, but how the 4 elements of standardized performance measures, transparency and public reporting, payment innovation, and informed consumer choice will shape home health care moving forward. So, without further ado, I'll hand it over to Jennifer to begin the discussion on value-based purchasing.
Thank you, Sam. So let's go ahead and get into the meat of the home health value-based purchasing model. We're looking at 6 different quality domains when we think about the organizing components for CMS. And those domains are clinical quality, patient safety, efficiency and effectiveness, population health, patient satisfaction, and care coordination. So what are we going to be graded on? They basically take all 6 of those different quality domains and they condense them down to 4 for the home health value-based purchasing model. So classification 1, we have clinical quality of care, which I'll be going over with you in just a moment. Classification 2, we have care coordination and efficiency. Classification 3 is the patient and caregiver-centered experience. And classification 4 is new measures. So let's look at the starter measures for home health value-based purchasing. So these are the quality measures for those 9 states that are participating in the first year of the value-based purchasing model. There are 6 process measures. There are 10 outcome measures, there are 5 home health CAHPS measures, and 3 new measures that we've never reported on before. So there's a total of 24 total measures that CMS will be looking at and grading us on regarding value-based purchasing. So what are those guiding principles of those starter measures, or why did they choose these particular ones, and how did they think about, or what decisions did they make to decide which of the measures to use? So the guiding principles are basically based on broad measures that capture the complexity of the home health agency service provided. Now we know that we're a different entity than any other brick and mortar type setting, so therefore we have to really capture that in our quality measures. The flexibility is also there to include the Impact Act measures across post-acute settings. So again, we're trying to line up the quality indicators for home health, for long-term care, and for other types of post-acute settings as well. We also know that these are second-generation measures of patient outcomes, health and functional status, some shared decision-making, and patient activation. We're also looking at processes and outcomes, a balance of those, as well as factoring in that patient satisfaction. We can do everything in the world, and if the patient is not happy with the care they're receiving, obviously we have an issue. CMS wanted to be able to have the ability to measure both cost and values, and some measures for appropriateness of overuse to see if there are agencies who are overusing resources, and then finally to promote infrastructure investments. The objectives of these 24 measures particularly are that they are predominantly drawn from OASIS and home health CAHPS, which we already do. So if there's any good news, the good news is we're going to be measured on things that we already are doing for our patients and we're already gathering information. There are only 3 exceptions to that, and we'll get into that in just a bit. The objectives are also to emphasize measuring patient outcomes and their functional status. Again, you think about the bigger picture, and that is increase quality, reduce cost. So, of course, the outcomes and the functional status is going to be a big deal. We want to look into appropriateness of care, and this backs right up into CMS's guidelines. They've always got us on reasonable and necessary. The care that we provide must be reasonable and necessary, and again, that shows appropriateness of the care that we're giving. We need to make sure that the measures can show incentives to measure quality data. In other words, CMS is trying to find out if agencies will actually do better if they are incentivized, if they're going to make more money for doing a better job or less money if they don't do a better job. Then are they going to perform better? And I bet if the state of Texas were in this, we certainly would perform better here as well. We also try to line up with the national quality strategies when we're looking at our measures. And of course, the biggest goal is to improve health outcomes, the quality, the safety, the efficiency of care of patients using best practices. So what's the big deal? Again, the focus is outcomes. Traditionally in home health care, we have focused on payment and how that payment is provided, but now we really have to focus on our outcomes and our quality. We must be able to prove what we know, and that is that we're providing great care. We just have to now prove that. And the way that we'll do that is because our payment will be tied to quality and outcomes. And we'll also have that factor of the patient's perspective and the patient's experience. That's what the CAPS piece is all about. We want to make sure we're keeping elderly and vulnerable populations healthy, and we will be seeing some of those measures in the 3 added measures that we've never reported on before, such as reporting patients who've had shingles vaccines. And then lastly, we want to make sure that the coordination of care between the patient and the family and the caregiver, the other disciplines, the physician, that all of that is also proven and well documented because that improves the patient's care. Okay, let's look at the clinical quality of care here. These are outcome measures that come directly from our OASIS, and as you can see here, the questions that are being looked at as far as improving the patient's outcomes are M1860, where the patient would want to see an improvement in ambulation and locomotion. Also 1850, improvement in bed transferring, 1830, improvement in bathing, and M1400, improvement in shortness of breath. Now, when you think about why CMS is particularly looking at these things, there are many different things that come to mind. One is the utilization of therapy services. CMS has always felt like we in home care overutilize therapy services. And especially when you look at OASIS in those quality episodes from the start of care to transfer or discharge, or from resumption of care to transfer or discharge, oftentimes either from poor skills of the assessing clinician or for other problems, comorbidities, whatever, oftentimes you'll see that there's not a real good improvement in the patient status before and at discharge. And most of the time in my experience, the reason for that is that the assessing clinician has likely overrated the patient's abilities on start of care. And there's many reasons for that, but primarily that comes from training. You know, they haven't had the proper training, or they feel rushed and they don't do the proper assessment. Maybe they conduct it as an interview, the OASIS assessment, instead of actually seeing the patient perform these different skills. And then as they get to know the patient by end of care, they have a better feel of how the patient performed or can perform now, and so you don't always see that improvement. So you need to make sure you have tools in place, maybe OASIS scrubbers or different tools that can flag and let you know, hey, you don't have any room for improvement here. So the other things that you have to think about is your onboarding process. Of course, you know, if we're going to be graded on these, we want to make sure that we have clinicians who know how to properly assess patients. So my experience has been, of course, with 20 years in home care, working everything from field staff to DON to administrator. Oftentimes when I would move state to state or take new jobs in home health agencies, you know, your first day you think you're going to get some training and orientation, and quite often what would happen, I would go in on my first day of the job thinking I'm going to read policies and procedures and learn, you know, if they're CHAP or JCO accredited and so on. And first day in, I'm handed a couple of admissions and a recert, and it's kind of like, here you go. And I've always wondered, how is it that we at home health agencies think that just because someone has experience that they know how to do an OASIS. You have no way of assessing that if you don't have a good program in place. So I suggest that you make sure that you do some kind of competency to make sure your clinicians know how to fill out an OASIS properly, that they have good assessment skills, that they really know what they're doing, because this is going to impact you financially in the long run if you don't do that. Okay, so those are the clinical quality of care outcomes measures. There's also a process measure for clinical quality of care, and that's M2015, and that's drug education on all medications provided to the patient or caregiver during all episodes of care. So what Medicare is trying to measure here is what are our processes to make sure that our patients are taking their medications properly and that they've been educated not only on what the medication looks like, but the reason they're on the medication, the possible side effects, when they're going to call the physician or the clinician if there's an issue, all the different problems, interactions that might be going on, and how they know that medication's working properly. So we really have to make sure that, again, we have processes in place. Do our clinicians know how to do a medication reconciliation properly? Are they just copying a list from the discharge from the hospital or facility, or are they literally going through the medications? And I can tell you from experience that can be timely, and sometimes we see people make shortcuts in that department, but you really have to be very adamant about seeing the patient's medication bottles, all of them, and they'll have them everywhere. They'll be under the bed or in their handbag or in the side table, in the bathroom, in the kitchen, all over. But oftentimes when you do a good medication reconciliation, you notice that that patient has medications that are expired. They may have duplications because they don't realize that brand names and generic names are the same drug, for example, or they may have herbals that the physician doesn't even know they're on that can interact with other medications. So it's very important that we do this, and we do this every visit, and certainly at each time point that we're doing an OASIS to make sure we're providing that medication teaching. And the reason that's so important is because one of the number one reasons patients are rehospitalized has to do with improper medication administration and all the adverse effects that can go with that. So this is, again, one of those process measures that CMS is focused on for a good reason. All right, then we have some population community health outcomes and processes that are collected from the OASIS as well. And we have 4 here on the slide that we're looking at. These 4 are process measures. Process number 1, M1041, which is where we assess if the patient is being seen during a period of time when the influenza vaccine is supposed to be administered. So the question is, does the episode of care include any dates on or between October 1st and March 31st? Of course, that's very easy to answer. All you have to do is look on the calendar and see at what period of time are you assessing the patient, and does it fall within that period. This is one of the things that OASIS C1 changed from OASIS C, and it made it easier to answer these questions properly. The next one we have M1046, which is the influenza immunization received for current flu season. So we've just found out if we're in the current flu season, and now has the patient had a flu injection. And why is that important? Well, with the seniors and the disabled persons that we care for in home care, when they get the flu, it's a lot bigger deal than if you and I get the flu. If we get the flu, we may be debilitated for a couple days, maybe a week. If our seniors and people who have multiple comorbid conditions get the flu, they're looking at pneumonia and death possibly. So we want to make sure that we just head that off in the beginning by simply getting them immunized. M1051 asks about the pneumococcal polysaccharide vaccine. Has the patient ever received that injection? And of course, with the flu and the pneumonia vaccines, we certainly want to make sure that yearly we're looking at the CDC's website, gathering information about the population that they're trying to focus on with the pneumonia, those who qualify for the injections, those who are not needing to have pneumonia or flu injections, and so on. But 1051 on our OASIS asks if the patient has ever had a pneumonia vaccine, quite simply. And then the follow-up at M1056 asks why they've never had one if they've not. Maybe they are allergic to the components of the vaccine, or maybe they're not the correct age that they should be receiving the pneumonia vaccine and so on, but we should be assessing that specifically and recording it in our OASIS. And of course, if they haven't had injections, we should be advocates to make sure that they are, we're letting the physician know that the patient's instructed on why it's important and so on and so forth. Okay, so we're going to continue to talk about these 24 measures. I'm just going to go over what the 24 measures are and where they're coming from, and then we'll have Dr. Andrew and Marvin come in and elaborate on those that they have worked up for us as well. So communication and care coordination are two of the things that CMS is looking at as well. We have an outcome and a process measure in that regard coming from the OASIS again. So on M2420, what CMS is looking at is whether or not the patient was discharged to community. So of course, since home care is one of the lower cost options for patients and getting the care that they need, what we want to make sure that we are achieving is that that patient is able to stay in the community after home care is completed. We don't want to finish home care and then they go to the hospital again, or they end up in a long-term care facility, for example. We want them to be, the best outcome is that they're independent and safe and discharged in the community in some setting. And then there is also a process measure at M2102 that has to do with care management, the types and sources of assistance the patient gets. So again, the focus is safe and independent, low-cost care. What is the patient needing in order to stay at home or in the community? Do they have all the things that they need? Do they have an adequate caregiver? Do they have meals? Do they have someone to make sure that they're safe, or are they safe at home? So that process measure 2102 really talks about the types and sources of assistance the patient has in order to remain at the home. Now we have efficiency and cost reduction. Again, remember that big focus we talked about is increasing quality and decreasing payment, decreasing the cost of taking care of this patient. There are two things that, of course, CMS begins to look at here, and that is whether or not the patient is hospitalized during the first 60 days of home care. And how will they know that? Well, they'll know that by the claims. So during the episode, the payment episode for home health, if that patient ends up being admitted to the hospital, of course, the hospital is going to bill for that. And the claim will show up with the same Medicare provider number or beneficiary number, and that will trigger to CMS that while they were on home health services, the patient went to the hospital. There's another claim and outcome measure, and that is emergency department use with or without hospitalization. So even if the patient didn't get hospitalized during our 60-day payment episode, if they go to the emergency room, then that will also be something that CMS looks at. Because again, we are trying our best to keep them out of those high-cost settings. And it doesn't make sense if we're getting paid to do that for them to then end up at another facility and they're getting billed for both services, right? So we have to really focus on the quality of what we're doing, okay? We have 3 new measures that we'll be reporting, or those that are in the home health model will be reporting. And that gives us some insight as to what we that are not in the model still need to be thinking about and where CMS's mind is. So these 3 new measures that those people who are in the home health value-based purchasing model are having to report beginning this year kind of gives us some insight into what CMS is trying to achieve. One, population health, and also trying to make sure that the patient's wishes when it comes to end-of-life matters are taken care of. So we have 3 process measures that will be self-reported by home health agencies in the 9 states currently in the home health value-based purchasing model. And the portal, what they'll have to do, the agencies will keep up with this information, and at an appointed time, they will submit their response to all of these questions into a CMS mandated portal. So think of it almost like exporting your OASIS to the QEIS or home health portal for that. We'll have a portal designated just for these measures. And the measures that we're looking at here are influenza vaccination coverage for home health care personnel. So when CMS is talking about the personnel, they literally mean those people who are employed by the home health agency, including contracted employees or volunteers. We are to also, between October 1st and March 31st, now monitor our staff and make sure that they are also receiving flu injections, and if not, why not? Do they have an allergy to the vaccine and so on? And why is that important? Because again, if we get the flu, we could be contagious before we even know it. We go out to see the seniors or debilitated population that we serve, we could be giving them issues that we've brought into their home and make them sick. And we don't want to do that, of course. It's important for us as caregivers and providers to make sure we're vaccinated as well. There's another measure that has to do with the herpes zoster or shingles vaccination, and this is for our patients. We're simply asking, has the patient ever received the shingles vaccination, yes or no? And we know, again, we need to go to the CDC's website and see what age range of patients we're talking about here. We need to make sure that we ask the patient if they've ever had the shingles vaccination, and then if they've not, we need to recommend that they get that. And why is that important? Studies have shown that shingles vaccines in people who are over the age of 60 or 50 years old, they have more complications, especially things like post-herpetic pain. And so those can drive cost as well. They can make the patient need more care, more services, and certainly if you've seen a really bad case of shingles in a senior, during my nursing career, I saw one that was broken out here on the side of the face along the eye. And that patient stayed hospitalized for a very long time on my floor. So again, we're trying to just head that off before it even happens by getting that shingles vaccine. The last new measure that we have has to do with advanced care planning. And it's not the same necessarily as advanced directives. What the advanced care plan talks about is for those patients, we already know that we have to let them know about advanced care directives and provide assistance with getting those done if they want to do so. But what often does not happen is the patient's wishes are often not transferred from one setting to the other. So if the hospital has, for example, a DNR or living will or information, that's often not transferred to home health or to hospice and so on. So what CMS is looking for is not just do they have advanced directives, but what are we as an industry doing to help make sure that that patient's wishes are communicated with other healthcare settings and that they've talked to their caregiver or their family member about what those wishes are. Because they can have this all documented, and then when something happens, the family members get frantic and they may not follow with the patient's wishes. And I've seen that happen quite often. So we're trying to, again, facilitate those conversations that need to happen with the patient, with the people who care for that patient, to make sure that their wishes are honored when the time comes and they can't speak for themselves. All right, we also have a few outcomes that have to do with patient safety. We have M1242, which is improvement in pain interfering with activity. M2020, improvement in management of oral medications. And M1900, what was the patient's prior functioning ADL and IADL ability. Now, why is CMS looking at those? And Dr. Andrew will elaborate on this again in just a little bit. But why are we talking about pain and oral medications and prior functioning levels? Well, because it's kind of an important thing to know when you look at what your outcomes and goals are those outcomes and goals realistic, number one? Are we trying to get the patient better than what they were before they had this episode of illness? Or was the patient pretty much not functioning very well to begin with, and are we going to make a huge difference? So we need to find out where they were before and where we can get them as far as realistic expectations. We also need to think about pain and activity. If the patient's grimacing when they move around, or if they're sitting around because it hurts to move, they're going to have poor outcomes, obviously, and that can cause some muscle atrophy and many other problems that can increase falls and so on. And then finally, again, the oral medications, we know that's a big deal because if they're not taken properly and the patient can't take their medications properly, that's a huge risk factor for rehospitalization. The last few measures that we have to deal with come from the CAPS report, and of course these are the CMS mandated, so you can think of them as patient surveys if you'd like, but the ones that CMS are actually looking at for measures for value-based purchasing have to do with the care of the patient, communications between the providers and the patient, some specific care issues, the overall rating of home health, and willingness to recommend the agency. So you can see a lot of it has to do with satisfaction of the patient Is the patient aware of the services that they're getting? And is that communication there? And so on. Here we have just in a table for you the clinical quality domain. And again, the good news is that we are already doing this stuff. So if we tighten up our training and our knowledge on the OASIS, we will have better episodes. But what I want to show you in this table is how CMS is kind of grading us in each of these domains. So what they'll do for those that are participating in the home health value-based purchasing, they're going to take the number of episodes that have less impairment at discharge than they did at the start of the episode. And by episodes, we're not talking about payment episode, we're talking about quality episodes. And just to remind you, a quality episode starts at either start of care or resumption of care, and it ends when the patient's transferred or discharged. So you could feasibly have 2 or more quality episodes within one 60-day payment episode. So if you had a patient admitted on day 1, day 15 they go into the hospital, day number 20 they come out of the hospital and a resumption of care is done, and then we're discharging at day 60. As you can see, you have 2 quality episodes and one 60-day payment episode. So they're looking at the quality episodes here, and again, the number of episodes when the patient had less impairment at the end than they did at the beginning. And that will be the numerator for the variable. The denominator will be the number of episodes that end in a discharge. And that's where how they're going to grade us for both ambulation and transferring. That will also be how they grade us on bathing and shortness of breath. The last one we're looking at is clinical quality M10-2015. That has to do with the drug education on all medications, and because this is a process measure, what they'll do, they're going to look at the number of quality episodes where the patient or caregiver was instructed to report or monitor their drug therapy issues, and then they're going to look at, for the denominator, the number of episodes where the discharge or transfer to an inpatient facility occurred. Okay. For population health, again, that has to do with the influenza vaccines. It's just a process measure. They're really not going to use that to grade, but they're looking to see how many episodes we had between 10/1 and 3/31. And then for M1046, they're looking at the number of episodes where either the patient received the flu vaccine or they received the flu vaccine from an earlier episode or from another provider. And then they're going to use as the denominator the number of episodes that ended with a death or a discharge or a transfer to a facility. So end of care, basically. The same will happen with your pneumonia vaccines. And then the population health that has to do with home care providers, again, we're going to self-report that in a portal that CMS has set up, as well as the shingles vaccine for our seniors and our patients. That will also be recorded in the web portal for self-reported. Now, I do want to let you know there were some measures that were not finalized in 2016 for home health value-based purchasing. And again, we want to talk about this just to let you know, again, which way CMS is thinking here. The ones that were not finalized for this year were timely initiation of care. In other words, are you following the condition of participation that says you must admit the patient within 48 hours of referral, right? So if it's not within 48 hours, it's considered not to be timely initiation of care. So we need to make sure that we are doing that, of course, and following that COP, but if we can't do that for some reason, that we have documentation. And normally that would just be that the patient refused to let you come out during that window of time. Another measure that was not finalized for this year was pressure ulcer prevention and care. We had multi-factor fall risk for all patients who can ambulate, and by that they mean the standardized tests like your MOC-10 or your TUG test. So they want, and you can see from these measures that weren't finalized, CMS is really looking at best practices and quality. Are we providing those things? Are we making sure we're getting out there early enough to catch problems after discharge? Are we making sure that the patient is being assessed for pressure ulcers and prevention and care if they have one? Are we making sure that we're thoroughly assessing the patient for ambulation and risk of falls? And then we have an adverse event for improper medication administration and side effects, which was a new measure. It's not currently measured anywhere in the OASIS. And from what I remember, the reason this one was not particularly finalized is we're trying to line up that measurement across settings according to the Impact Act, so this one's not ready yet. And then finally, did we do a depression assessment on all our patients? So again, these are just best practice measures, things that were not finalized this year, but we've seen from the hospital value-based purchasing that they may very well be included in the next set of measures. So with the hospital value-based purchasing, what happened quite often, hospitals would improve so much on the quality measures that they didn't have any more room for improvement or for financial gain. So again, those measures would change if either there was no more improvement to be made, or if that measure was felt not to be a proper one, didn't work out well, and so on. So again, the measures for home health value-based purchasing can change at any time through regulation. So the biggest question when you look at all of the things that we're being measured on and that we're going to get paid for if we're doing a good job, the question that will come up is, how are you going to measure that quality internally? Okay, before CMS gets the information and publishes it on your 5-star rating or your home health compare, how can you measure internally and make sure you're going in the right direction? Number one, make sure you have a wonderful QAPI program in place. You want to work on quarterly QAPI projects. Look at the data that you have. Maybe your outcomes are not good in ambulation, although you're using a lot of therapy. You might choose that to focus on for this next quarter, educating the staff and looking at outcomes and what the problem is and trying to improve that. So you're going to want quarterly QAPI projects going on at all times. You're going to want to look at your CASPER reports, which you can download. That will tell you about your demographic of patient. For example, if the national patient age for Medicare beneficiary on home health services is age of 72, and your demographics in your CASPER report shows you that your patients tend to be 82 years old on average. Of course, you know that your outcomes are going to be different than that 72-year-old average, and what are you going to do to accommodate that big difference? You also want to look at your home health CAHPS reports. You want to make sure that you're using a vendor that gives you wonderful data back about the CAHPS reporting that was taken care of, the patient's responses, the number of people who participated, and you would be able to drill down and see not only the time frame that you're looking at currently, but a look back period so you can look for trends over the last year and so on. You're going to want to keep up and look at and study your PEPR reports data, your home health compare and your 5-star ratings, your internal reporting as well, employee orientation process, and your employee skills assessments. Again, I can't stress enough how important it is. You may have a wonderful nurse who knows all about wounds, but they may not know enough about cardiac or medication reconciliation or whatever. So we have to make sure we have well-rounded, independent employees in home care. At this time, we'll go ahead and turn it over to Marvin, who's going to come up and talk about how he at Better Care Home Health and their organization improved several processes that have to do with the patient transition and communication and such that we're being measured on as well. So Marvin, come on up.
Thank you, Jennifer. Hi, my name is Marvin Havliana. I'm CEO of Better Care Home Health in Des Plaines, Illinois. Better Care Home Health is a Medicare certified agency specializing on high acuity patients. Today, I would like to talk to you about care coordination and efficiency and effectiveness. This is how we could save a lot more money and increase our margins for our home health agencies. In this day and age, CMS is cutting our reimbursements. We need to find other ways of increasing our profits. What I'm going to show you today is one way of doing so. What I also am showing you is a template of care coordination that you could build upon. It's also a flow of what Better Care has been doing for the past 3 years that you could improve upon. So let's look at care coordination first. Now on the screen, we have an enhanced home health protocol that Better Care Home Health has adopted in the past year and a half. Let me walk you through the key important points, and I'll explain to you why we have chosen this particular protocol. First is our pre-discharge hospital visit. We have assigned a home health liaison at every single referral source that we have. We send them for every single discharge. Now why? Why do we do that? Our goal is to have proper, good communication not only with the patients, but the patient's family, and also with our staff at the office. This ensures that we get the proper documentation post-discharge. Therefore, it makes an efficient start of care for the visiting nurse. We will have mitigated some of the errors that could happen, like, for example, medication reconciliation. Number two, what we do have here, if you look at the slides, we have a tuck-in phone call. Our tuck-in phone calls are designed so that we could ask the patients how they like their clinicians. This then enhances our patient satisfaction. Now imagine you being a patient and you're not happy with your nurse. What happens? You're not compliant. We like our patients to be compliant because that's one source of readmissions, is non-compliance to their medication and to their ADLs. So we do ask the patients if they are satisfied with our clinicians. One other thing that is very, very important is communication with the POA or the family. That is also addressed on our protocol. The last very important part here is calling the patient 15 to 30 days post-discharge. That will be the last box at the bottom of your slide. And the purpose of this is to make sure that the patient did not decline. And if the patient declines within this 30-day readmission, for us, we could call the patient's POA, we could call the patient's primary care physician and address the issue, whether we need to add more visits, readmit the patient, or simply assist them in their needs. Now we will continue to the next slide, which will show an example of efficiency and effectiveness. Now, mind you, this is what Better Care does. This might not fit your needs, but it is a template for you to start with. It is a very important fact that you have to have a process. Without process, things will fall apart. You can't ramp up, you can't scale up, and you can't be efficient. That means that you're wasting money. So let's go to that slide. This next slide represents Better Care's intake process. Now, mind you, this is Better Care's intake process. This could be a template for what you have to do to create your own process. I will walk you through key important points that I think is very important for proper admission flow. As soon as we get a referral from either our EFACS or ESIN, we right away do an HIQH, which is an eligibility check. We do a pre-authorization if it is a private insurance. Then we do a PACOS verification. Why do we do this? We do this because we believe that if we have the right information from the beginning, everything will flow smoothly down the line. The next important thing is the review of our Director of Nursing. She reviews each and every case that comes in and makes sure that we could handle, or is the patient appropriate or not. This is where it will end. If the patient's not appropriate, then what we do is we inform the liaison or the account rep so that in turn they could communicate that to the referral source. Now that's very important, communicating to the referral source. You do not want to string along that referral source to the last minute and decline the patient. That you will never get a referral again. Now moving on, we enter that referral onto our EMR. We have invested a lot of money into our electronic medical record and also other technologies like eFax. Now, bringing it all together, we have created a more efficient workflow. I'm telling you, EMR is the key. So if you are still on paper, please find yourself an EMR, just like what we use. We use Axxess for our EMR, which is a very robust medical records system, and we're very, very happy with it. Next, we go to the admission process. Once we've verified, entered, now we see whether we could admit the patient or not. We look at our staffing needs. Do we have staff in that area? If not, we go back to the liaison and say, hey, we can't take the patient. And again, going back to that communication process. Another important thing that we do really is also taking care of DME, infusion, and lab works. We coordinate all of this. We also understand that if anything goes wrong at the patient level, we are going to be blamed for it, and not the labs, not the DME, and not the infusion company either. So we take that into our own responsibility so that we could take control over it. And if anything goes wrong, it's our responsibility, not somebody else's. Next in the flow is checking back, looping back on all of the DME, infusion, and labs. Looping back is making sure that all of these labs, DMEs, or infusion supplies are delivered. And if not, we go ahead and we follow up. Lastly on our process is the verification of the primary care physician. That's who we send a face-to-face. That's where we send the plan of care. That is the most critical part. Now, we have instances way back before we've created this process that we've sent this to the wrong physician. That's not going to happen again because we have verified the primary care physician prior to us even doing the start of care. Now, what does that do for you? That makes sure that you send the documents to the right person. It speeds up the orders management process, and it speeds up your being able to bill for your wraps. Now that we have seen Better Care's processes, what are the key takeaways here? The key takeaway number one would be having invested on a robust EMR, just like Axxess, just like what we have. Having a robust EMR allows you efficiency. Number two, making sure that we have a process to implement this EMR, which is a tool for efficiency. Now, the third is going back to that process and making sure that that process works. Otherwise, you do a tweak and you implement and then you check back again and if it works. Now that we've seen these slides, what is important to you? Scalability, efficiency, growing your business, and surviving the onslaught of Medicare cuts. I encourage you to look at them and see if you could modify these slides, make it fit your company. I really encourage you to do that. That's the only way that we could do it. That's the only way we could survive. Invest in a good EMR. Be compliant. If you're on paper, go get a demo as soon as possible.
Hi, this is Dr. Andrew Awunin. During this section, I'll be talking about the patient safety domain. The patient safety domain is one of the domains in the value-based purchasing model program, and within it, there are three measures. Again, these are starter measures, and this is CMS's way of ensuring that we're addressing, at least in the home health setting, all the measures that impact ultimately the patient's safety. As we all know, improvement in pain interfering with activity is a major determinant for how much activity a patient will engage in. And so M1242 is the measure that's been selected for it. The outcome there is for episodes that patients have for them to improve in their pain management, or the official line says episodes where pain is less than in the beginning of the episode. How does CMS count episodes? As we've mentioned elsewhere, an episode is a start of care with a discharge or a resumption of care, and it's essentially has to be a complete start to finish episode where the patient's been discharged. It doesn't matter when they started care, where they've been discharged during the measurement period. And so the measurement period for CMS started July 1st of 2015. For the purposes of value-based purchasing, it will be starting January of 2016. So whether you're in a value-based purchasing state or not, this is still a measure that should be of interest. It's also reported on the Home Health Compare website, and we'll mention that as one of the sources of data that you can use to set your baseline or to measure on an ongoing basis. So, what is M1242? The question M1242 is related to the frequency of pain interfering with a patient's activity or movement. There are 5 options ranging from 0, where the patient has no pain, to 4, where they have pain all the time. What are we trying to measure here? Essentially, what we're really looking at is how we're looking at a snapshot in time. How much pain is the patient experiencing? So when assessing M1242, what we need to look at is the patient on pain medication or not? Regardless of whether they're on pain medication or not, when we're starting their care, or if we're assessing later on, what pain do they have, or how does it restrict their activity? And that's how we're grading them. And so either the patient has pain that interferes with their activity or movement, or maybe it's slight and it's not daily, or it is daily. And so selecting the right option. How do we improve this score? Well, we need to start by knowing where we're at with this measurement. Some potential sources are a chart review. Having electronic documentation definitely makes a difference, and in some cases your software vendor might even make it easy for you to quickly pull charts and look at specific M items. In between looking at charts, and a good place to start is just taking a small percentage of your charts. Let's say you just start with 1% of the total number of patients that you see in a month, and you just take a look at the documentation around M1242. You can increase that over time to maybe 5 or 10%. If there's not an issue, you can move on to another measure. Another place you can go to look at is your CASPER reports, specifically the All Patient Risk Adjusted Outcomes report, where you'll actually find a graph, or you'll find your numbers. The numbers that you're really interested in looking at, and you ideally want to do this quarterly, at least quarterly. You want to look at your current quarter eligible cases and what the percentage is. Compare that with the prior reporting period, and also the national, so that you're using the national as a benchmark to determine where you're at as an agency or as an organization. The other place to go and look is on Home Health Compare. For those who are not familiar with Home Health Compare, you can go to the Medicare.gov website /Home Health Compare, or you can type into any browser Home Health Compare, search for your agency after typing in your zip code, and you will see what's being publicly reported. Or clearly there are vendors out there that collect this information and make that available. And that's something that we do at Axxess. Some areas for potential improvement: once you know what your baseline is, you want to work on educating your staff, including it in in-services around Mood 1242, and working and ensuring that everyone understands how to answer the question. Other corollaries that you might look at are M1240, 2250, and 2400D. And what those are really looking at pain intervention and ensuring that there's a plan of care, and that we're following up on appropriate interventions, contacting the provider and documenting that. So that's the first measure. The next measure in the patient safety domain is an improvement in oral medication administration, which is M2020. And the outcome, or the sought outcome there, is that patients improve in the oral administration of medication, or taking their medications orally. And so this particular measure, again, determining your baseline, same sources, looking at your CASPER reports, looking for those line items, whether they're numerical or graphical, that show you how you're performing in the current reporting period, how you performed in the previous reporting period, and then how that compares nationally. If you're doing well, and you are doing well by a wide margin, clearly you can move to another measure, while you continue to keep an eye and be sure to applaud your staff and ensure that, let them know that you appreciate how well the organization is doing overall. If you're not doing as well, then it is an opportunity for you to, once you've determined your baseline, to go back, work with staff in understanding that particular question. And that question, again, has 5 items where the patient is able to independently take their medication orally once, and that includes whether it's been set up for them where they can take it without any reminders, or they set it out themselves. Even if your providers are setting up the pill boxes or the medication cabinets for them, and you don't need to remind them, in that case, they're taking it independently. If they need some assistance with either having that set up or having reminders, or if they're unable to take that appropriately, those would also be documented within M2020. And again, the focus is oral medications. So when assessing, remembering that this is strictly oral medications and does not include injectables, topicals, or any such medications. And then monitoring on an ongoing basis once you've put together a performance improvement plan, if this happens to be a measure where you're scoring very low in, making sure that after the training that you're doing some spot reviews of your charts along with on a quarterly basis, or after takes about 6 to 9 months on Home Health Compare, watching to see whether those measures are increasing. So your Casper reports or your vendor is definitely the best person to help you with looking at some of that data in real time and using those tools. The last category is the prior functioning ADL and IADL. Now this is an interesting one because it's not currently being reported on Home Health Compare and is not in any of the current Casper reports. ADLs and IADLs are clearly something that's extremely important when we think about the quality of care. If a patient's stable and they're really not going to improve because they happen to have a disability or because of their diagnosis, at least ensuring that we stabilize them and keep them stable. And the outcome here is to improve the patient's usual ability with everyday activities prior to his or her most recent illness, exacerbation, or injury. So as we can see from the outcome that CMS is highlighting here, that if they're pretty much where they were at before their prior illness, exacerbation, or injury, there's really not a whole lot we can do. We'll just need to ensure that they do not get worse. The numerator for this is the proportion of the clinician's patients in a particular risk adjustment diagnostic group, which CMS, at least as of this time, has not released. And so it's something that we'll be continuing to keep an eye on and update you accordingly. And so again, we're looking at the ADLs and IADLs, assessing the patients on their range of dependency to being independent, and documenting that accordingly. You will not find this particular measure in your Casper report at this point in time. I won't be surprised if we see that make its way into the Casper reports and eventually onto Home Health Compare. So chart reviews are probably your best route for determining your baseline and monitoring this on an ongoing basis. If you happen to be in a state where you are required to participate in value-based purchasing, you will be receiving these reports on a quarterly basis starting later in 2016. And so I would definitely take a look at those reports and use those on an ongoing basis to monitor your progress. You definitely want to work with education of staff and ensuring that you're monitoring this. On Home Health Compare, there are a number of measures that are there. Not all of them are, and so at least the ADL related measures, you can use those to either determine your baseline or to monitor what's being publicly reported. It won't give you a complete picture, but it does give you a window into how you're performing overall. Thank you very much, and look forward to the next time we meet.
Thank you for joining our webinar today. We know that your time is valuable and are happy you chose to spend it with Axxess. At Axxess, we're proud to offer a variety of training resources to keep you in the know on industry news and updates. You can register for additional trainings and watch on-demand training videos through our software or at axxess.com, where you can also find tutorials, online manuals, and answers to frequently asked questions. We're always just a call or click away. Feel free to call us at 866-795-5990 or email us at support@axxess.com. All of our expert client experience representatives have a home healthcare background. They've been in your shoes and know the industry inside and out. Join the conversation and connect with us on our social channels. We'll keep you up to date with what's going on in the industry and share resources to help you grow your business and improve your patient outcomes. Thank you again for your time today and for choosing Axxess, your provider of complete home healthcare services, software, and solutions.